It's a real pleasure to introduce the final session of today, which is the David Harvey Senior Fellowship Lecture. David Harvey will be known personally to many of you in the room. David was a consultant neonatologist and paediatrician at Queen Charlotte's and Chelsea Hospital between the years of 1970 and 2002, and during that time also served as head of department for paediatrics and neonatal medicine at Imperial for part of that time. David really is recognised as being instrumental to the foundation of training in neonatal medicine, which evolved into its own recognised entity during that period. And he was a big promoter of trainees. And I remember myself in 1999 experiencing his training in a departmental presentation. David was also well known for pioneering the care of women and children, particularly in areas that were less established at that time, one example of which was the use of donor milk. And of course, his contributions to the professional life of doctors and should not go unrecognised too in his foundation of GLAD, the Gay and Lesbian Association for Doctors and Dentists, in 1995. So David was very involved in the society. He was an ordinary member of the committee from 1971 to 75 and progressed to become meeting secretary and general secretary over the rest of the 1970s. And it was following his death that his estate set up a generous bequest which enabled us to provide this fellowship to the Neonatal Society, which enables us to fund with an honorarium an eminent member of the neonatal community who's contributed to science and learning over the decades, particularly in areas that are underserved. So it's with great pleasure that we welcome Professor Linda de Vries. Could we move the slide on, please? To be the recipient of the David Harvey Senior Fellowship Lecturer for 2021. She follows a line of fantastic speakers over the past 5 or 6 years, and we're delighted that she accepted our nomination for this year. Linda trained in paediatrics and neonatology in Utrecht and also in paediatric neurology in Leuven. And from 1989 until 2019, she worked in the Department of Neonatology at the University of Utrecht, becoming a chair in 2001. Linda's contributions to scholarship in neonatal neurology and neonatal neuroscience have been absolutely prolific. A search of Scopus reveals that she's got just under 500 peer-reviewed publications. She's co-authored 3 books. And these have largely been focused around neurology, imaging, neurophysiology, and post-hemorrhagic ventricular dilatation, stroke, and plasticity in particular. I think a striking feature of looking through Linda's publications are twofold. The first is that she's a collaborator with many other senior neonatal neurologists from around the world, which I think reflects her sort of outward-looking team science approach to solving the problems of neonatal neurology over the past 3 decades. And the second thing that strikes is the number of trainees that have worked with Linda and gone on themselves to build significant academic and clinical careers. So it's with great pleasure to welcome Linda as the 2021 David Harvey Senior Fellow.
Well, thank you so much for this very kind introduction, James. Really very nice. Thank you. And it's a great privilege and real honor to be here and to give this dedicated lecture. And the title of this lecture is really a little bit daunting. And as you can see at the top, it's difficult to know where to start. And it's really a big task. But of course, I would like to start with David himself. And I had the privilege to know him when I was working at the Hammersmiths in the mid-80s. And once a week, I would go to Queen Charlotte's Hospital to look at the ultrasound pictures that were performed the week before. And he was always such a gentleman and so welcoming and so kind when I would come to his place. And in the middle, we also see a typical picture when he was a chair of one of the British Council meetings. It's really also a great pleasure to give this talk at the British Neonatal Society, because my first talk ever in English was over there. And I was working for Malcolm Levine at the time, and I was there to learn how to do cranial ultrasound, but he also asked me to look at the size of the kidneys. And this was a paper we did together in 1983. And of course, it's a severe disappointment that I cannot be there in person today. So let's look at the progress over these 3 decades and start off with use of cranial ultrasound. And on the left, we also see images that were performed by Malcolm in the late 70s. And it's really amazing that we dare to say anything at all. On the left, we see a baby with an IVH, and we do see the bleed. And we also can see post-hemorrhagic ventricular dilatation. But of course, it's not possible to say anything at all about the periventricular white matter. If we look at a similar case from just a couple of months ago, then we can see that indeed there again is a small bleed. There is some post-hemorrhagic ventricular dilatation as well. But unfortunately, now we can appreciate that there are also cysts in the white matter, especially on the right. And in a case like this, we like to perform an MRI at term equivalent age to look not just for cysts, but look at myelination of the posterior limb of the internal capsule and gliosis as well. And we can see that on the affected side, the most affected side, the myelination of the posterior limb is not really seen very well. And it's also a little bit sparse on the less affected side. And we can see still some cysts, but also some glial scars, these white dots adjacent to the lateral ventricles. So a more complete picture than in the late 70s. If you do the same for cranial MRI, then we had the privilege of working with James Bidder in the 80s and doing the first MRIs ever in the preterm and term babies. We used the 1 Tesla magnet, and there we would be sitting next to the baby for an hour or so and just get a few single slices. But in this full-term baby with HIE, we did get the right slice, and we can see that there's increased signal in the thalami and the basal ganglia, and this child developed dyskinetic cerebral palsy. But now we moved to 3 Tesla or maybe even 7 Tesla in some cases and get 1 millimeter slices. And we can have high resolution early and at term equivalent age. And of course, also we can use these advanced imaging techniques like the DTI in this particular case. So I think over the first 2 decades, we were looking mainly at overt brain injury, the big 5, I would like to say, the hemorrhages, also in the cerebellum, and cystic white matter injury, and for the full term, HIE and stroke. And this would give us information on a patient level. We would talk to the parents and predict outcome. Over the last decade, also because these overt brain injuries have come down, we are mostly looking at non-overt brain injury, which even with MRI is difficult to see. In these, we are using more advanced MRI techniques to also predict school age outcome. And this will be mostly on information on a group level rather than information for an individual patient. And we can see here cortical folding and tract-based statistical analysis. Let's look at first for cystic PVL. On the left, we see an example in the mid-80s with extensive cystic lesions, and we would see about 10 babies like this every year. And now we see once every 18 months a baby with extensive cystic PVL. Below, we can see the decline written by one of our PhD students in babies at 32 weeks or less. And we can see that the decline in cystic PVL is coinciding with a decline in the rate of cerebral palsy. And this does make sense because cystic PVL is the main predictor for cerebral palsy. So from just over 6% to less than 2% for cerebral palsy and just over 4 to 0.4% in the last period. If we look at the more recent baby, we can see focal cysts in the white matter, as well as a large germinal matrix hemorrhage. And then after another period, looking again with MRI and ultrasound at term equivalent age, we no longer see the cyst, but we now see glial scarring. So it's extremely important to perform serial ultrasound to not miss the cystic stage, which is so predictive of outcome. And also we can appreciate that the glial scars are not just punctate white matter lesions, but are often sequelae of previous cystic lesions that one would miss if doing only a single term equivalent age MRI. This is an interesting small observational study by Claudia Roll's group in Germany. And here they looked at the association of hypocarbia and white matter injury. So they had 21 infants born at 28 to 31 weeks with cystic PVL, and they looked whether these infants had hypocarbia. And what was very interesting is that you can see that the majority of the children with cerebral hypocarbia never were ventilated. They were the children without any respiratory support. And that is what we experience nowadays. The cystic PVL babies are not from the NICUs, but they are actually coming from the level 2 hospitals, where sometimes they get these children, and therefore it's really important that they perform cranial ultrasound also in these level 2 centers. If you look at the pathology paper from Joe Volpe's group from 2007, it's striking and well studied now that if you have a lesion which is extensive and cystic in the white matter, then the area of injury is not restricted to the white matter, but will affect also other parts of the brain, like here, especially the central gray nuclei. So this is a lot less if you just have diffuse white matter abnormalities, but for cystic PVL, this is quite impressive. And we were able to look into this together with Sabrina Council and Carina Kersbergen, one of our PhD students. And I'm really grateful for Sabrina for the nice collaboration between Utrecht and London for so many years. So Carina went to London with the MRIs of the children with cystic white matter injury and combined them to the ones from London. And we can see here already visually, looking at this child with early severe confluent diffusion abnormalities, also in the posterior limb of the internal capsule. At term, there are cysts, and we can see that the thalami look really small, and there is no myelination of the posterior limb of the internal capsule. Looking here at the volumes, there is no significant difference on the first MRI at around 30 weeks. But when done again at 40 weeks, at term equivalent age, we see that there is severe delay in growth of the thalami in these children. A step further was taken by Stephen Miller's group, and we can see here a map of all the lesions, the punctate white matter lesions, built into a template. And in pink are the areas where the scores on the Bailey were less than 85. And if we look at the graph on the left, we can see that for the cognitive outcome, the abnormalities were mainly present in the frontal lobes. And for the relation with the poor motor outcome, we see that they extend into the parietal periventricular white matter. Looking at growth between 30 and 40 weeks, again, Carina looked into this, and we can see that the cerebellum is really, really growing fast, 258% between the first MRI and the MRI at term equivalent age. And therefore, it's not surprising that the cerebellum is very vulnerable and susceptible to hemorrhages as well. Here we see a case from the old days in 2003, where we were only scanning the children through the anterior fontanelle and therefore missed a lesion, which subsequently resulted in this severe atrophy of the cerebellum, especially the right cerebellar hemisphere. So this child was scanned later because it presented with severe learning disabilities. And going back to the first image, then probably there was a bleed in this area. But nowadays, looking through the mastoid fontanelle, we can appreciate and get nearer to the cerebellum and get wonderful images from both cerebellar hemispheres. So we can see nowadays, if you use the mastoid window, a hemorrhage, if it's more than 4 millimeter in diameter, we can confirm it on the early MRI and see the center becoming less hemorrhagic. And then at term equivalent age, we can now appreciate the resulting atrophy. And again, new techniques are there. And here a study from UCSF in San Francisco has shown that if you have a large IVH, it will affect your cerebellar volume. And this will be even more affected if you have a bleed right into the cerebellum. So cerebellar hemorrhages can be recognized with ultrasound if they are more than 4 millimeter in diameter, but they will be better detected if they are smaller, especially with the MRI, and especially so with this special sequence called the susceptibility weighted imaging, which shows these lesions very clearly, and especially the punctate lesions, which can never be recognized with ultrasound, are best seen with SWI or T2 weighted sequence. Again, a group from Stephen Miller looked into this using these cerebellar hemorrhage maps, taking 36 children together, 14 of these with punctate lesions, and showed that these hemorrhages occurred mostly in the inferior aspect of the posterior lobes. The total volume of the cerebellar hemorrhage was independently associated with motor outcome at the age of 4.5 years. And the size of the cerebellar hemorrhages was associated with visuomotor integration and also externalizing behavior, but interestingly not with cognitive outcome in this series. So if we move to the children with periventricular hemorrhagic infarction, then we again see a case from the mid-80s, and those who worked at the Hammersmith will probably recognize him as well. There's a large hemorrhage on ultrasound in the brain parenchyma, and a later MRI also shows that there is severe involvement and injury to the right occipital part of the brain. However, this child has done remarkably well. Nowadays, we can look in more detail and we see this hemorrhage in the brain parenchyma showing this triangular lesion, which follows the veins in the white matter. And we can see this also here clearly on an early MRI. Here we see another site where a hemorrhage can be seen, and this is in the temporal lobe. And interesting as well are the punctate lesions in the cerebellum, which were missed with ultrasound. So we looked at a large group of children with periventricular hemorrhagic infarction some years back, and we saw that the unilateral spastic cerebral palsy was seen in about half of the cases with a lesion in the parietal lobe. However, the lesions which were seen in the temporal or frontal lobe were not related to motor problems, but especially for the temporal lesions, more to cognitive, behavioral, and visual outcome. If you can do an MRI really early during the first week, then you can take advantage of the diffusion weighted imaging. And we see in this baby at the top during the first week that there is restricted diffusion in the posterior limb of the internal capsule. And if you repeat the MRI at term equivalent age, then we can see that the lesion has become cystic, but we can also appreciate that the myelination seen as a dark line over here cannot be recognized here. And this will be highly predictive of subsequent development of unilateral spastic cerebral palsy. We can also take it a step further and perform diffusion tensor imaging. And this was already performed at the end of the first week in this baby who had bilateral involvement of the brain parenchyma, hemorrhagic venous infarction. So we were keen to know whether both cortical spinal tracts, seen here in blue, were affected. And if that would have been the case, then we might have gone for redirection of care. But actually we see that the blue line is preserved on the less affected side. So at term equivalent age, we can confirm this. There is now myelin on the less affected side with a small area of gliosis, but no myelination on the more severely affected side. And this is also still seen with the DTI, the color-coded map. And indeed, the boy developed a hemiparesis and at 6 months is only playing with his left foot. So to get this information early, you can even at the end of the first week use DTI to see this. James asked me to talk a little bit more extensively about post-hemorrhagic ventricular dilatation. And I think what is really important and so nicely summarized in this scheme from Volpe's textbook is over here. In a baby, there will be a large extracerebral CSF space. So it will take several weeks before the cavity is filled and we can see symptoms developing in this infant. The fontanelle may get full and the head may start growing excessively. And we can see that here on the MRI as well. There's quite a lot of space, even though the baby only has got this small hemorrhage. So the cavity takes time to be filled. And there was even a paper written about this in 2014, showing a poor correlation between head circumference and cranial ultrasound findings in infants with PHVD. So the question has always been when to start intervention of post-hemorrhagic ventricular dilatation. And most are still using the clinical signs, irritability, rapid increase in head circumference, or wait till the +4 millimeter line on the Veen graph has been crossed. I always try to do this earlier and not wait for the crossing of the +4 millimeter line, but follow the direction of the increase in ventricular index. And if you do this, you also look at ballooning and you look therefore also at the anterior horn width and start your intervention maybe a little bit earlier. So is there support for adverse effect of PHVD? Well, there are many, many studies now looking at cerebral hemodynamics, nerve physiology, and also biochemistry, and they all point in the direction that large ventricles are not a good finding. Is there balance in favor of early intervention? Well, that's a difficult question because, of course, if you intervene early, you're more invasive, you perform more surgery with anesthesia as well, and there's always a risk of infection. However, by doing so, you hope to preserve your white matter volume, get fewer ventriculoperitoneal shunts, and also eventually improve neurodevelopmental outcome. So let's briefly talk about the two randomized controlled trials. The first one done by Andy Whitelaw in Bristol, who spent a lot of time during his career on PHVD. And we can see here data from the DRIFT trial. And of these 70 infants that were enrolled, we see that there is no difference for mortality or placement of a VP shunt. And unfortunately, a third of the children had a rebleed during the DRIFT procedure. However, at the age of 2 years, there was a significant difference in outcome, especially for the severely impaired outcome, less than 55 on the Bailey-2. And this was the case for those who were treated with DRIFT. They were performing better. And then they were even able to look at these children again at the age of 10 years, which is quite an achievement. And they concluded that the proof of principle is that secondary brain injury is reduced by washing away the harmful debris of IVH in a controlled way. And here we see the data. And even though the outcome is not good for either group, 69 in the DRIFT infants and 53 the cognitive scores in the standard arm, this was significantly different after adjustment for sex, birth weight, and IVH grade. So let's move to the ELVIS trial. And this trial actually took 10 years to enroll 126 babies. And they could be enrolled if they developed PHVD following a grade 3 or periventricular hemorrhagic infarction. So once they consented, we started to measure the ventricles on a daily basis. And once they were going in the direction of the +4, the babies were randomized. And if they were into the low threshold group, they would immediately get lumbar punctures, and otherwise we had to wait till the +4 millimeter line had to be crossed. And otherwise the therapy was similar for both groups. So we see that the anterior horn width was either above 6 or above 10. And for the higher threshold group, we had to wait for crossing the +4 millimeter line. Then we would do a few lumbar punctures, and similar to Charles, I like doing them in a sitting position of the baby. And then after a few lumbar punctures, if they were still needed, we would ask the neurosurgeon to insert a vesivar. And then after about 4 to 6 weeks, we would do a challenge if we still needed to do punctures. And if the challenge told us that the child did get larger ventricles once again, we would ask the neurosurgeon to put in a shunt once the baby was about 2 kilo or so. So the clinical data were not different for sex, gestation, birth weight, or parenchymal involvement. If we look at the intervention details, then we see that the babies who were treated late were treated about 5 days later than the early ones. Of course, we were performing more lumbar punctures and putting in more vesivars. And in the end, there was no significant difference for needing a shunt or dying. However, the number of children needing a shunt was very, very low, about 20%, which is the lowest reported in the literature so far. Then Mehmet Chismetchi, who is now a fellow in Toronto, together with Stephen Miller, he looked at the MRI, which could be performed in 88 of the 126 babies. And looking at the Kido-Koro score, we can see here that there is a significant difference in favor of the low threshold group. We also looked at volumes in a subgroup of infants where the quality of the MRI was sufficient to do the volumetric analysis. And we can see here that there was a significant difference in favor of the low threshold group for the ventricular volume and for the combined white and gray matter volume. We then looked at their 2-year outcome, and we were able to do a Bailey at 2 years in 96 of the 126 infants. And the only difference for clinical characteristics was that the low threshold infants had a mechanical ventilation more often for more than a week. If we look at the table on the left, we can see that there were no significant differences, but it's very nice to see that the cognitive score on the Bailey was within the normal range for almost 3/4 of the infants, and this applied to 2/3 of the infants for the Bailey motor score. The majority of the children had the Bailey 3 performed, and we also can see here that cerebral palsy was classified according to the GMFCS. If we look at cerebral palsy, we can see here that only 1 out of 36 infants in the low threshold group actually developed cerebral palsy, and overall only 8% of those with grade 3. For the children with the venous infarction, just over half developed cerebral palsy, and this was a unilateral spastic CP in 70%. We then looked at the composite adverse outcome, which was death or cerebral palsy or a Bailey less than 2 standard deviation, which was 35% in the low threshold compared to 51% in the high threshold group, which became significant after adjusting for gestation and severity of the bleed. And then finally, we combined all the infants and looked at the fronto-occipital horn ratio on the MRI at term equivalent age, which is really a proxy for volumes. And we can see that the larger the ventricles, the worse the outcome on the Bailey, both for the cognitive as well as the motor score. And then together with the group in St. Louis, and Stephen Miller, we were able to look into this and were able to make a kind of traffic light to tell people when to do, when to watch, and when to act. And the conclusion is that do not wait for clinical symptoms. Earlier intervention is associated with better outcomes. So this has been taken even further with new technology, and here we see a paper using DTI. And we see here the data for the optic radiation. And we can see that for the children with post-hemorrhagic hydrocephalus, the data were worse. And even, which is interesting, I think, they were worse compared to the children with cystic PVL. And then the group in St. Louis took it even a step further. Here they also look at the DTI, and they look at the corpus callosum, the posterior limb, and the optic radiation, and found these significant differences between the controls and the children with post-hemorrhagic hydrocephalus. But they also looked at the biomarkers, and they related the biomarkers to the fractional anisotropy values in the corpus callosum. And you can see here the significant relationship, which I think is very interesting as well. And then some in South Korea, they have started to inject mesenchymal stem cells into the ventricles in children with periventricular hemorrhagic infarction. And they first had this phase 1 trial where they looked at 9 infants. And I must admit that I find that some of the MRIs do not look very nice. So here there are no conclusions to be drawn, and it's a safety study, but they are now enrolling patients in a phase 2 study. So let's move to the non-overt brain injury and the use of advanced MRI techniques. And here I think we change from a single patient to the group-based analyses. And there are so many papers out there now that I just selected a few, and I hope not to offend anybody that I'm not selecting theirs, but it's about nutrition, pain, music, sedation, sleep, and socioeconomic status. So here is the big dilemma. We all know this. You look at a baby who's just admitted at 24 weeks and the brain looks very, very smooth, but it's really filling the cavity. And then at 30 weeks at your first MRI, the brain still looks preserved and there are no major lesions to be seen. However, at 40 weeks, repeating the MRI, you can see that there has been really insufficient growth of this really sad looking brain. So what happens? Well, some like Julian Snyder together with Stephen Miller looked at nutrition. And I think this is a very interesting paper because they didn't only look at nutrition and looking at the brain volumes, which were better in the high energy and lipid intake group up till term equivalent age, but they also looked at the association of ventilation duration. And we can see here in red the children who had high ventilation but low energy intake. So if you had high ventilation and a better intake, then the line was a little bit better than this red line. So very interesting, I think, and something we should be considering. Then here, a nice paper about breast milk from James Boardman group. And we can see that the amount of breast milk was also predictive of the better connectivity in the FA-weighted connectome. And this was also dose dependent. So those who were receiving more than 90% exposure were doing better than those receiving less. Again, very interesting data. I had the pleasure to be working with Stephen Miller on a pain study, and this was following the nice work by Emma Durden, published in 2018, where they looked at the number of skin breaks up till the first MRI performed at 30 weeks. And we can see that the volume of the telemi was smaller in those who had most skin breaks, which was up to 300 up till 30 weeks postmenstrual age. However, in Utrecht, we were always leaving the lines in for a longer period of time than in Vancouver. Well, we did take the lines out after about a week, the arterial line and the central venous line. But then if the child was still ventilated, we would replace these by a radial line and by a PICC line. And we found indeed that the number of skin breaks was much lower in Utrecht. And this was associated with a better thalamic volume on the first MRI. And then the growth of the thalami between the first and the second MRI was predictive of cognitive outcome and motor outcome at preschool age. And here we can see the differences, the children from Utrecht in green and the children in Vancouver in blue. And we can also see here the relation with the early thalamic volumes and the median number of skin breaks up to 30 weeks in the two centers. So again, this is something we can work on and do something about in our daily practice. And here another study from the same group. And here they looked at the relation between a drug, midazolam, and the growth of the hippocampi. And there was, with a higher dose of midazolam, smaller growth of the hippocampi. However, looking at this population, you can see that the same amount of midazolam can result in a very small hippocampal volume, but also a good hippocampal volume. And that's what I mean. It's really suitable for a group, but not so much for the individual patient. And then a very interesting study where they looked at the socioeconomic scale. We all know that we are always looking at maternal education and how important it is. And we can see that in the graph over here. If the maternal education is less and only there is primary or secondary school, this graph shifts to the left. However, if you look at this part of the figure, then it becomes really very interesting. Because if the mother had a postgraduate degree and the baby had some brain injury, then we see that it didn't really matter whether the baby did or did not have brain injury, because the outcome was more or less the same. But if you go to the moms who had only primary or secondary school, then there is a huge difference between the children with or without brain injury. And this difference is really, really significant. So I think this is a very interesting way of looking at the data as well. So let's move for the final part of my talk to the children who were term and developed HIE, and a lot has happened in this area especially. So let's again start with a baby in the mid-80s, and I already showed this slide, a baby with basal ganglia and thalamic injury. And clinically, the baby was having a seizure. If we move to the 90s, then we were looking at conventional imaging and looking especially at whether the prick was myelinated or not, and looking, of course, at injury in the basal ganglia or the white matter, and using analog EEG. In the last decade, we have moved to DTI and TBSS, and also more using spectroscopy data. And here we are now using digital AEG and more often a full EEG in these children as well. So a lot really has happened. So in the 90s, Mary Rutherford published this landmark paper about the abnormal myelination of the posterior limb of the internal capsule, which was very strongly related to outcome with a very high sensitivity and specificity. And in 2011, Francis Cowan and Miriam Martinez-Biarge had this really good paper in neurology, again looking at the posterior limb as a predictor of independent walking and development of cerebral palsy. I especially like this paper, which was published a year earlier, where they went into great detail, because it's not just about cerebral palsy, it's about so many other things as well: feeding, speech, vision, DQ, and seizures. And for each degree of injury to the basal ganglia, they have such a wonderful flow diagram, which is really very helpful when you counsel the parents. We also developed a scoring system, and we did this to also be able to appreciate injury which was less severe, and also be able to say whether there was an IVH or whether there was a sinovenous thrombosis or injury to the cerebellum. So by doing this, we had all the abnormalities which we saw on the MRI. And we found that this was predictive of outcome at 2 years and also outcome at school age. And especially this applied to the gray matter subscore. An adverse outcome was composite of death, cerebral palsy, and poor Bailey or WIPSI scores. And here we see the area under the curve, which was good both for the 2-year as well as the 5-year, 5 to 7 year outcome for the gray matter subscore. So Marianne Thorsen will talk about her new data. So I'm not going into this, but it's very interesting, this total impairment score on the MRI and calculating the white matter and the basal ganglia score. You'll hear about that tomorrow. In a meta-analysis which we did last year, we have shown that looking at all these data together, that the MRI is more predictive when it's performed in the first week compared to the second week. And this is probably because the diffusion makes scoring the MRI a little bit easier. If we look at all these lesions, we can see on the left the major ones, the injury to the basal ganglia and the thalami, the watershed type of injury. In the middle, the punctate white matter lesions, and below the severe white matter lesions evolving into a large cyst in the white matter. And on the right, we see the hemorrhagic stroke, the ischemic stroke, and CSVT, but I will not be talking about these. So we are much better now in monitoring the brain, and we do this with continuous AEG and EEG, and we can see a status epilepticus in this baby with a near total brain injury. We can look with ultrasound, and we should, and the abnormalities become apparent over the first couple of days. And if we perform MRI early, we can see the changes on the diffusion here throughout the brain, but especially in the cerebral peduncles and also in the thalami. And we can appreciate this very large lactate peak on the spectroscopy, the proton spectroscopy as well. And in a child with watershed injury, again, the early diffusion is very helpful. It's much easier to see than on the T2 sequence on the left. The corpus callosum is usually involved. The child has got a repetitive seizures on a discontinuous background. At 3 months, the lesions are difficult to see, and we have to wait a little bit longer till we can use a so-called flare sequence. And now at 7 years, when the baby is lying still, has become a child, we can see the glial scarring, which is much less severe than we would have thought initially on the basis of the diffusion findings. And the outcome was normal up till 5 years of age. Other techniques like the arterial spin labeling to look at perfusion has been used by one of my colleagues. And we can see here at the top a normal MRI, and below a child again with severe injury where the ASL shows hyperperfusion. And this was also recently reported by Tortora from Genoa. And looking also at the MRI and spectroscopy, we found that the combination of spectroscopy and arterial spin labeling was the best predictor of outcome. A review paper by Margaret Dibble published a couple of years ago looking at 19 studies using DTI and concluding that the posterior limb of the internal capsule and the corpus callosum were often showing lower FA values, and these were related to subsequent outcome. So I think when you are doing an MRI, it's easy nowadays to also include the DTI. And then, of course, the AEG and EEG are very important. This is a study from Geraldine Boylan's group showing that the seizure burden, the total seizure burden, median, maximum seizure burden are significantly related to outcome. In this study, they did not look at MRI, but they did say that the association was independent of HIE severity, and seizures per se were not associated with an abnormal outcome. So it's really important to perform continuous EEG in these children as well. And then, of course, the main game changer has been hypothermia. And this is a landmark paper by Marianne Torresen and her colleagues at UCH at the time. And here we can see in the piglet that there is preservation of the spectroscopy data in those who were cooled compared to the normothermic piglets. So it moved to the infants, and here are 2 studies, 2 MRI studies by Mary Rutherford and Jeannie Chong, showing that there was a reduction using hypothermia in white matter injury, basal ganglia thalamic injury, and in the study by Mary also of the posterior limb of the internal capsule. And if the injury is there, it's as predictive for outcome as before. And hypothermia has also been shown to reduce the seizure burden, as we can see in this study by Geraldine Boylan very clearly. So altogether, the 18-month outcome shows a lot of data now in studies in favor of hypothermia. And below we can see that everything is also better except for deafness. And looking at these two childhood outcome studies, we see that the babies from the TOBY trial did a lot better than those for the NICHD trial, but still there are children who still have a moderate to severe outcome. And if you look at the children which were done at 6 to 8 years by the group in Bristol, they were able to look at about 30 children without cerebral palsy born between 2008 and 2010 and age-matched controls for sex and social class. We can see that overall, they were performing worse, even if they were cooled, with an average 14 IQ points lower and a 10-fold increased odds of requiring additional support at school. And a more recent study looked at disrupted brain connectivity in children treated with hypothermia for neonatal encephalopathy. And in these 33 cases, we can see that there is widespread reduction of fractional anisotropy across the brain, and especially in the fornix, the corpus callosum, the internal capsule, and the cingulum. So let's finally look at the corpora mammillaria, the mammillary bodies. And I didn't even know they were there, but our pediatric radiologist, Martin Lecoin, pointed this out to me some years ago now. And he said, you really should look at these babies that are being cooled and have neonatal encephalopathy, because I very often find these mammillary bodies to be abnormal. And these are part of the PAPES system, and they're connected to the anterior thalamic nuclei and related to the hippocampal formation, and are related to memory function and also cognitive outcome. And we found them to be abnormal in about 40% of our infants that were scanned. And in half of these, the brain otherwise looked normal. So this is what they should look like on a T2 and a T1, and you can only clearly see them if you use 2 millimeter slices on your MRI. And if it's abnormal, then they look very, very high signal intensity on the T2 and very swollen as well. And if you're within your diffusion weighted imaging window, you can see them there as restricted diffusion. And in this case, combined with diffusion abnormalities in the hippocampi as well. So if you look at a child again, even within a couple of months' time, and sometimes even within weeks, you see atrophy of these mammillary bodies. And this stalk, there should be a small round area, but it's completely gone. So we looked into this, and this is another PhD student, Kim Anning, and we found that if these mammillary bodies were atrophic, whether you were cooled or not, because we also saw it in the cooled babies, this was related to the total IQ, performance IQ, processing speed, and episodic memory in both normothermic and hypothermic infants. So this may explain why some of our children at school age with a normal looking MRI, if you don't look at the mammillary bodies, then maybe these mammillary bodies explain part of their problem. So I like this expression of Donna Ferrero from UCSF, who says we need cocktail on ice. And there are many studies out there that are looking these neuroprotective agents like allopurinol for the albino European trial, melatonin, the xenon, where the trial from Bristol is still not out. We're looking forward to those data and the data from Duke about the cord blood cells for HIE. So there is a lot that's going to happen there. And these are data from the phase 2 trial from the EPO in HIE, where already in the phase 2 trial, they were able to show a significant improvement of the MRI score, especially for the basal ganglia and thalami. And we hope that the phase 3 trial, the data will come out early next year. Then there are these two trials that I'm not going to talk about, of course. These are led by Manon Benders, the dinosaur trial using DARBE for neonatal stroke, and the PASSION trial, a feasibility and safety study where we just included 10 babies and hopefully we can continue with the phase 2 trial. That is really all very, very exciting. So the main changes over the last 3 decades, there are so many, but neuroimaging, I think, has completely changed our understanding of brain injury. And there's still an ongoing debate about the use of MRI in preterm infants at term equivalent age. And we just written a commentary about this, which just came out. Minimal handling and non-invasive ventilation has really helped to reduce severe brain injury in the preterm infants, especially cystic PVL. MRI and AEG have become standard of care in full-term infants with neonatal encephalopathy and/or seizures, and hypothermia has been the major and most important change, I think, caring for a full-term infant with HIE. So where to next? Well, don't worry, I'm not going to talk about it because I find it very, very complicated, all of this, but it's all about artificial intelligence, machine learning, and deep learning using convolutional neural networks. So that's, I think, the future for now. And you get papers looking like this, very, very complicated, but at the same time also very interesting. And I'm looking forward what is coming out of these important new data sets. So we have come a long way, but we still have a very long road ahead of us. And I think that you have to be really, really lucky when you're working in this field, having the right mentors like Lily and Victor Duwich, who taught me everything about neonatal neurology, Paul Kazar, who taught me about pediatric neurology, and you have to enjoy working together with people like Francis Cowan, who has always been the bridge between London and Utrecht, Floris Groenendaal, my colleague and friend from Utrecht, Stephen Miller. I had the pleasure of working a few times in Toronto, and also Silke Steggerda, who works in Leiden, where I am working a little bit now after my retirement as well. And I would like to thank you very much, and I will let you go quickly to have your drinks, unfortunately, without me being there as well. Thank you.
Thank you, Linda. That was a tremendous tour de force, really, on the massive advances of MRA over these last 3 decades, both in prognosis, diagnosis, and really understanding upstream processes to atypical development. So thank you very much for that. We do have time for 1 or 2 questions, if anyone would like to question or comment. Linda, I'm seeing questions flash up, I think. I would be keen, Linda, to know your views really on the role of MRI in randomized control trials when we can examine the effect of an intervention on the actual brain tissue. And of course, many of these trials have used FA and TBSS to date. In your view, do you think we've used the right markers so far? Should we be thinking of others?
I think it's if you do multi-center study and you're using DTI as well, it's a little bit difficult. I think it's important, and I think we should be doing it. But we know that even in one place, if you have 2-3 Tesla magnets, your DTI, your FA may vary a little bit from one machine to the next. So if you do it, and I think that's what they did do for the EPO trial in the States, that they went there with a phantom to every center, and they made sure that they were getting the same, as much as possible, the same FA values from the different machines. Because otherwise, I think, well, we say apples and pears, and you say apples and oranges, but I think then it might be difficult. But yes, I think it's a way forward, and maybe also volumes, like for the stroke trial, we are looking at volumes as well as DTI.
Thank you. We have one question that's come through on the feed from Colin Peters in Glasgow. Fantastic talk, thank you. How should the jobbing neonatologist take the research findings into practice for the preterm infant, e.g. less than 28 weeks? Should every baby be enrolled in a trial of care which includes MRI?
Um, Well, I think MRI is a very good tool when you're doing research to look at the effect of whatever intervention you're going to do, clinical intervention or medication or new technology. I think that at present, at least it's much better than performing ultrasound. But again, if you're doing your MRI, it should be done well. And if you do a multi-center study and you get MRI data from a lot of different centers, it's sometimes very hard to look at data from other centers. So I think we have to get better in making it more equal. Everybody is using the same slide thickness and similar sequences. Then I think it's a magnificent tool to take MRI as part of your outcome.
Okay, well, I think it's 5:30. We better wrap up, but thank you very much once again, and delighted to hear that you'll be continuing to do some work in Leiden in your retirement. So thank you. So that closes the meeting for today, and we'll look forward to seeing you all bright and early tomorrow morning. Thank you.